Hello, I'm Dr. Sarah Sibbeston, and on behalf of myself and Dr. Dana Rivet, I'll be going over pregnancy after laparoscopic radiofrequency ablation, a case report. Laparoscopic radiofrequency ablation, or Lap-RFA, is a relatively new technology being implemented in the treatment of uterine fibroids. The procedure is comprised of laparoscopic ultrasound to visualize fibroids within the uterus. Then an electrosurgical probe is inserted into each fibroid, and radiofrequency ablation causes coagulative necrosis, destroying the fibroid tissue. Lap-RFA is currently indicated for the treatment of fibroid symptoms such as abnormal uterine bleeding, bulk symptoms, or pelvic pain. It is not currently indicated for infertility or approved to treat fibroids in patients who wish to become pregnant afterwards. There have been cases of pregnancy outcomes reported in the literature which so far have seen laparoscopic RFA as equivalent to myomectomy, though additional data is needed. In Edmonton, there are currently 2 surgeons at one site who have been using Lap-RFA since July 2023. Our patient presented as a 32-year-old G0 with several years' history of menorrhagia and dysmenorrhea, attributed to her known uterine fibroids and adenomyosis. At the time of presentation in 2018, she had had 4 years of infertility and was seeking uterine-sparing treatment of her fibroids as she wished to conceive. In May 2018, her initial surgical intervention for the treatment of her fibroids was an open myomectomy through a fan and steel incision. Intra-op, a 10-centimeter fibroid occupying most of the posterior uterus, extending into the posterior cul-de-sac was seen. An additional 5-centimeter fibroid was seen on the left cornua. A second surgeon was consulted intra-op, and ultimately both fibroids were felt to be unresectable without carrying a high risk of a hysterectomy. The case was then concluded with no complications and minimal blood loss. The patient was referred to a second surgeon at a different site in Edmonton. In June 2022, she underwent a second open myomectomy through an infraumbilical midline incision. 3 subserosal fibroids were seen anteriorly, 1 3-centimeter fibroid encompassing the right round ligament, 1 5-centimeter anterior fundal fibroid, and 1 2-centimeter left cornual fibroid. The largest fibroid was roughly 15 centimeters in circumference, located posteriorly, occupying the entire body of the uterus. Again, a second surgeon was consulted intraoperatively. The posterior fibroid was again found to be unresectable with a high risk of requiring a hysterectomy. Therefore, the case was completed with no complications and minimal blood loss. The patient was seen by an Edmonton fertility clinic in November 2022. She had in fact spontaneously conceived in early 2022, but underwent termination at 7 weeks due to severe nausea and vomiting, as well as pelvic pain. She was advised to pursue a surrogate with IVF and was referred back to gynecology for consideration of a hysterectomy to enable access to the ovaries for IVF. She was then referred to a third surgeon in 2023 for consideration of Lap-RFA. The goal was for symptom improvement and fibroid shrinkage to enable access to the ovaries for IVF, with plans to proceed with a surrogate. It was made clear to the patient that Lap-RFA had not been studied for the treatment of infertility and was not improved for the treatment of fibroids with intent to conceive afterwards. Pre-op pelvic ultrasound showed a 15-centimeter uterus with a dominant posterior intramural fibroid measuring 9 centimeters, as well as subserosal fibroids measuring 3 and 3.4 centimeters. She consented to the procedure and underwent Lap-RFA in December 2023. She was found to have an enlarged and boggy uterus that was easily compressible, compatible with diffuse adenomyosis. Attention was turned to the large posterior fibroid, which was suspected to in fact be an adenomyoma, involving most of the posterior uterus. The array was inserted into the fibroid and deployed a total of 12 times over 12 minutes and 30 seconds. The anterior uterine body was densely adherent to the anterior abdominal wall, from the lower segment up to the fundus. No other fibroids could be ablated because of this. The adhesions prevented contact of the ultrasound probe on the anterior uterine body. The case was concluded with no complications and minimal blood loss. The post-op period was uncomplicated. Here you can see images taken during the procedure, which show the boggy uterus and dense adhesions to the abdominal wall. You can also see where the probe has been inserted to access the posterior fibroid. The patient spontaneously conceived within 3 months of the RFA procedure. Her pregnancy was complicated by placenta previa, and she was admitted at 27 weeks for antepartum hemorrhage related to previa. In her 3rd trimester, she had several outpatient presentations to the hospital related to pelvic pain, which resolved with a pregnancy belt. She also had iron-deficient anemia requiring IV iron infusions. An MRI was done at 35-1 to assess for placenta accreta. There were more than 10 fibroids seen, mostly anterior and fundal. There's a 5.5 centimeter lower uterine segment fibroid, a 7.5 centimeter anterior fundal, and a 4.8 centimeter right parametrial lower segment fibroid. There was no evidence of invasion of placenta into the myometrial tissue. She delivered at 36-5 via elective primary C-section. Her section was technically difficult due to her several previous surgeries as well as the previa, and was done in the main OR under GA. Entry was complicated due to the dense adhesions. An anterior placenta was encountered and incised to gain access to the uterine cavity. A live male infant was delivered in the breech position, having been in a transverse lie. 2 small fibroids were present at the hysterotomy, which were removed to facilitate closure. The myometrium was grossly thickened, requiring a 5-layer closure. Ultimately, there was 1.7 liters of blood loss, but no other complications. This case highlights the complexity of treating fibroids with the goal of uterine preservation. After 2 failed myomectomies, which resulted in significant adhesions and no treatment benefit, she underwent Lap-RFA followed by a successful spontaneous pregnancy. Her pregnancy was complicated by placenta previa, transverse lie, and a complicated C-section. These complications were likely related to the significant uterine distortion, both from the adhesions and the persistent uterine fibroids. Studies are coming out in the literature that show promising results that Lap-RFA does not seem to significantly increase risk in terms of pregnancy complications and outcomes, though more data is needed before Lap-RFA can be approved for the treatment of fibroids contributing to infertility, and this is a future direction of study at our site. With that, I thank you for your attention to this presentation and open the floor to any questions.